So let's get started. So thank you everyone for joining today. Greatly appreciated. And so today we have Marchis Florin. So Marchis published with us back in 2020 on tracheal intubation. And so this was a very well received article at JoVE, got a lot of views and attention. So today he's going to update us on some recent developments to the technique, and feel free to ask questions in the Q&A, and then we'll answer those towards the end. And I'll also say that we're recording this webinar, and we will send it out to everyone by email afterwards, so you'll have that for your records. All right, so thank you everyone, and take it away.
Okay, should I go ahead?
Yep, go for it.
Okay, thank you, Ronald. So I work in Cluj-Napoca, Romania, at the Cluj County Hospital. I'm an anesthetist here. I have an experience of around 20 years in anesthesiology, most of it in ENT anesthesiology. And out from this experience, it came my study about airway, controlling airway, and controlling difficult airway especially. This project with a rigid tube for intubation, it is a part of my PhD thesis, which included some other chapters also. And it is a project that started in 2016, developed with actually 2 clinical studies, the first pilot study and the other study, which was published in JoVE. We have the other authors of this article, which helped me. Some of them were tutors in my PhD project. Some of them are just colleagues and partners with me. First, I'm gonna say a few words about difficult airway. Maybe some people attending this webinar are not familiar with it, but even if they are, I'm gonna point some of the important principles regarding the difficult airway. Usually, difficult airway is considered a situation in which an experienced anesthetist fails to perform either ventilation on the mask effectively, or he can't intubate, has difficulty in intubating and ventilating a patient, or even placing a supraglottic device. That's the universal definition of a difficult airway. Of course, as you can see, this has a lot of subjectivism in it, because it can be interpreted around the experience of the practitioner. So as a result, almost always a difficult airway is a combination of the patient anatomy and the characteristics, clinical context when this happens, and the skills, the moment skills of the practitioner which performs the airway control. The difficulty can be planned and treated accordingly. The practitioner can prepare for it, or the difficulty can be unforeseen, and probably this leads to the most of the complications. The airway management generally starts from these principles, from trying to assess the airway before the procedure, try to set up a plan how to approach the airway, try and prepare the equipment you plan you're gonna need for approaching the airway, and the airway approach. the airway management, which also has some stages, which are usually now updated regularly by different association of anesthetists. In general, you try to intubate 1 or 2 times. If you can succeed to intubate, you try to place a supraglottic device, and then you try some other. If you fail with that, also you try some other tools to control the airway or awake the patient. Or if that's not possible, you can assess and approach the airway invasively by percutaneously by an anterior airway approach, like a mini tracheal epicothyroidotomy. Of course, there is a team involved. There are drugs involved. I won't get into much detail of that. The idea is that incidents regarding airway control still happens. If we talk about anesthesia in ENT pathology, there is a high degree of difficulty in airway, and according to some studies, about 40% of complications related to airway management in anesthesia are from ENT surgery, and about 75% of cases where emergency surgical invasive access or anterior invasive access was required for cases of cannot intubate and cannot ventilate is also in ENT surgery. But also the airway management is necessary in some other situations, like in emergency medicine, even in pre-hospital settings. It's also necessary pretty often in the intensive care units, and this airway approach is not very much studied, but when it was studied, it was found that the rate of complication is much higher than in those airway complications related to anesthesia. So airway approach is not only an attribute of anesthesia, it also appears in settings like intensive care unit or emergency situations of different kinds. But coming back to our study, in ENT or in maxillofacial surgery, the airway is more difficult because there is a pathology involved, which usually it is around or in the airway. There is surgery involved of the airways, and that results in a more frequent difficult airway access, and the airway in ENT is not can be controlled just applying the universal algorithm for airway control. So starting from here, we try to find new tools and new techniques inspired from the ENT specialty to control the airway in the more efficient way. I didn't start this just by myself. There are data in literature which shows that different instruments from ENT practice can be applied with success in airway control. Actually, they are meant to visualize the airway, so it's somehow logical that they could be applied to control the airway. So the idea isn't new. What it is new that we try to design some prospective studies and try to prove if these tools are effective or not. Usually, what was written in literature before are all retrospective studies or case presentations, which indeed show that some of the instruments used in ENT practice were life-saving and they were rescue tools in different critical scenarios. So starting from here, our first instrument, which we used and try to study for efficiency in airway control, was the rigid tube, which is practically a kind of laryngoscope used by ENT specialists to visualize the larynx and its vicinity. We try to study this instrument and maybe find some ways to refine the tool, maybe the technique, to describe the technique in detail, as we did in our JoVE article, and try in this way to implement the technique to other practitioners and get better results with it. The rigid tube, it's as its name says, it's a simple tool. It's practically a tube which has a light source attached to a prismatic deflector. I have it here. You can see it, and this deflector has a tuner for focusing the light, which comes out from it into the tube. So to focus the light, to make a good view, which depends on how wide or how wide or how long is the tube. And the practitioner can obtain a good view just looking through this assembly. The tube is usually 15-25 centimeters long. It's a hollow tube with a bevel end, and the diameter can vary between 0.5 centimeters, which is usually used for very small adults or pediatric population, to 2 centimeters for large adults. As I said, the light source is attached, and you actually look through this assemble when using the tube. The first study, which was a pilot study, we used it on 20 patients, which were separated in two groups: a group with airway pathology, and we group with no airway pathology, but with some indices that will be a difficult intubation. We tried to find in this pilot study if the rigid tube is useful in different pathologies of ENT pathology, when where the classical laryngoscopy is difficult to accomplish. But also we try to see if this instrument could be efficient in patients with anatomical difficult airway, which had a lower grade of visualization of the glottis during classical laryngoscopy. So we excluded from this study, from the group with anatomical difficult airways, patients which had a Cormagley-Hain classification grade 1 at the classical laryngoscopy. That means that the patient which had a good visualization of the glottis during the classical laryngoscopy were excluded. We obtained good results in this pilot study. In both groups, we intubated all the patients except one, and included the patient with airway pathology with radiotherapy or oropharyngeal cancer, which had an unsatisfactory view at the classical laryngoscopy, were intubated with a rigid tube without any problems. Encouraged by this first study, we decided to start a second study in which to include only patients with anatomical difficult airways, which had the simplified airway risk index of difficult airway, which is a preclinical score of anticipating a difficult airway, suggestive for a difficult airway, and which had a very poor glottic visualization during classical laryngoscopy, which corresponds to 2B. That means that actually you can see the glottis during classical laryngoscopy. We also included in this study and in the article which resulted from the study, detailed protocol of the procedure, trying to show each step of the procedure, any pitfalls and any tricks of the procedure, with a purpose to make it as reproducible as possible, and also included with the help of the JoVE video with presenting the maneuver on a mannequin in detail. We included in this second study 30 patients, after excluding those with good visualization of the glottis. And we obtained good results with them also. We also had a failure in this group of patients, but we could intubate all the patients, and it proved that rigid tube was really useful and obtained a better glottis view than the classical laryngoscopy performed with the Macintosh laryngoscope. As I said, we in the protocol we presented in detail each step of the procedure. I won't insist on it. The mainstay of it is the retromolar or paraglossal approach, which is not a new idea. It's an idea which was present in literature, not very often, but it showed that it could be an advantage over the classical approach, which is in the sagittal line, because on the retromolar and or paraglossal approach, the advantage is that you bypass the base of the tongue, and you can approach the larynx without being needed to push the base of the tongue, which sometimes obstructs the good visualization of the glottis. So we presented in this study the steps and how to perform this procedure. You have the whole movie along with the JoVE article. As I said, we had we have good results with the study. We didn't have any complications or major complications. We didn't find some correlations which were statistically significant, only with the age. In a strange way, younger patients appeared to be more difficult to intubate with a rigid tube than older patients, but that could be somehow explained by the fact that younger patient had stronger tissues, and maybe they are more difficult to access the glottis in them, because they are not their tissues are not that lax. They are in older people. That could be an explanation. That's the only significant parameter we found in the study. The average duration of the maneuver with the rigid tube was around 50 seconds. Most of the cases, the intervention was fast. The glottis enter into field of the view in less than 25 seconds. And we had one patient which we could not intubate with a rigid tube, which was a Cormac 3 or 4, I guess, and we converted to laryngeal mask because the patient was desaturating, and we didn't want to jeopardize the patient. Okay, so why do we think that the rigid tube could be a rescue alternative, and sometimes, or maybe most of the times, could be more efficient than conventional laryngoscopy, or maybe even video laryngoscopy in some cases for difficult airways, especially when the larynx is situated anteriorly, or if there are some tumors or other processes involved which distort the airway. The first reason is because of the retromolar approach. The tip of the rigid tube can aim more anteriorly because it's bypassing the base of the tongue. Actually, it finds its way between the base of the tongue and the tonsils, and in this way, it can access sometimes when the base of the tongue is the problem, and most of the times there are studies saying that most of the times when the glottis seem too anteriorly, it's because the base of the tongue doesn't allow the blade of the conventional laryngoscope to leave the epiglottis properly, and in that way the glottis is not ready visible. Also, because of its tubular structure, the intrusion of the soft structures into the field of view is prevented with this instrument. Another advantage is that the approach is possible even for the right of the left-handed practitioner on both sides, which is not possible with the regular laryngoscope. And if there is let's say, something that obstructs the passage of the laryngoscope, like some mass, or there is bleeding on one side, or something that the other side can be readily available, and the airway can be approached on the other side. To use the rigid tube, it is important, of course, to have some kind of practice. I don't find it particularly difficult to use it. I can't declare myself an expert of using it because I don't use it very often. Also, I use it when we still use it when we really need it, when we think there is a difficult airway, or when we find ourselves unexpectedly in front of a difficult airway which we cannot control with other means. But of course, and for sure, to use it properly, you have to use it regularly, and in that way you can get a reasonable proficiency with it. What you have to know when using this tool is that thyroid cartilage is a landmark during rigid tube advancement. Also, it's good to measure or to approximate the distance from the labial commissure to the thyroid cartilage, because where the thyroid cartilage is, the glottis is also. And the advancement with the tube is have to be made with care. You don't have to rush things. Also, although in some cases the situation is dramatic, but it's important to take your time to watch and try to identify the structures, and most important, to try to reach and identify the epiglottis. Once the epiglottis is inside, everything becomes easier, because you can work with a rigid tube, and well, what you have to do next is to leave the epiglottis. Usually you leverage more retromolary and try to go with the tip of the rigid tube more anteriorly, and also you go beyond the epiglottis, and probably there's no there's the vocal cords in your side at that moment. It is important also, especially if you don't have too much experience, to start with a wider tube, so you can identify the structures, to find the epiglottis. And if a wider tube doesn't give you the glottis view you are expecting, you can go next to a thinner tube and try with the thinner tube, because always a thinner tube can intrude itself more anteriorly, but with the cost of smaller field of view. The rigid tube is a compact tool. It's easy to decontaminate, requires minimal setup, although you have to take a little time to focus the light properly. It's very important to have a good light when using the rigid tube. It's essential, I could say. So it's very important to focus the light, use the tuner I showed you earlier, and ensure yourself that the light is strong enough, because that at least partially can compensate the reduced view. Also, the blood or saliva, if it's necessary, can be aspirated through the rigid tube. So, as like a synthesis of what I told, the advantages of the rigid tube are obvious when oropharyngeal tumors are involved, when previous radiation therapy also it can be helpful, where are cervical masses also, which usually displace the airway. We found it also useful when there is reduced mobility of the head, or protruding incisors, or limited mouth opening, just because of the retromolar approach, which bypasses the incisors. Or if there is limited mouth opening, the tube is usually 1 or 1 centimeters and a half diameter, so it can be inserted into the mouth even if there is a limited mouth opening. There are some certain limitation of our study. I think the most important limitation is because the subjective perception. Maybe we found it useful, but there's no other studies so far, so we can be sure that our findings can be relied on. Maybe we found it useful to somebody else, but found it difficult to use or not useful at all. Also, we use it on a small cohort. And what was other minus of our study, that because we didn't want the patient to be desaturated and to put them in danger, maybe classical laryngoscopy was performed with celerity, and sometimes it didn't show the real cormac Glihane. Maybe if we tried better, we could obtain I don't know, maybe a better glottis view and a better cormac Glihane view. So the major disadvantages of the rigid tube, the biggest one is the reduced visual field, which can be a problem, especially if you use a thinner tube, a small diameter tube, or if there is excessive bleeding or salivation or vomiting. Theoretically, it's a higher risk of injury, but that's not sure. But because there is a lower visibility, probably the risk of injury is also higher. I repeat, if you use it wisely, the risk of injury is not, we didn't have any major injury, except for some, I don't know, lip injuries, more minor lip injury or something like that. Also, the intubation over the bougie is associated with other risks like vocal cords, trauma, or even the trauma of the lungs if the bougie is introduced too vigorously. I'm gonna show you now how usually, so this is a patient which we didn't have a good glottis view with a video laryngoscope, and we tried further with a rigid tube. So this is actually how the procedure works. We're looking for the, see, we already found the epiglottis. And now through the epiglottis, we're gonna stick the bougie, the intubating tube introducer. Okay, and then we just extract the tube and continue the procedure normal by intubating over the bougie. Sorry, we couldn't make a very good quality movie. Actually, we introduced a fiber optic device through the tube to film this movie. Conclusions are that we really think that the instrument is useful in certain situations when it needed, when you are or a practitioner finds itself in trouble. It can be really a rescue tool, because we found it that it can offer you a better glottic visualization in cases where classical laryngoscopy fails. Also, and for sure there is room for improvement, because the tool which we're using now, it's about 40 years old. It's not even made anymore. We didn't find any producer to produce it or to build, to fabricate it these days. There is for sure room for improvement for this tool. Of course, the light source can be built in. Also, the prismatic light diffractor could be improved. Let's not mention the tuner, which focuses the light. We always have the problem, we focus the light, and when we use the tube by mistake, we only touch a little that tuner which focuses the light, and we found ourselves that we don't have a good light, and we can't see anything. We I think if we had also some fails, but not too many with this tube. I think most of them were due, in my opinion, to this problem, because the light is very easy, let's say, I don't know, defocused, and if you are in a rush, in a hurry, or in a critical situation, you don't realize it right at the moment, and you find that the light is not working properly only when you get out and see that there is no light on the table, because the tool was defocused. So maybe if the tool, somebody will think to produce this tool, it could produce it with much, so a lot of improvements, so make it even more useful and more ergonomic, in my opinion. But of course, there is no interest so far, so we don't know. Maybe in the future this will happen. So we finish with a little French. This is, I don't know if it's all I wanted to say, but pretty much that's it. The rest is talk. And I'm waiting now for questions, if there are any.
All right. Thank you. Thank you. Very, very nice presentation. So yeah, if anyone has any questions, feel free to add those to the Q&A. And like I said, we will be sending out an email of the recording of the webinar afterwards. So if you think of any questions in the future, you can always respond to that email and we can help you out then. Let's conclude things then. So thank you to all the attendees for joining, greatly appreciated. And thank you, Dr. Marchis, for wonderful presentation.
Thank you, everybody.
All right, and enjoy the rest of your day, everyone.
Thank you.
Bye-bye.